So welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database Quality Improvement Series on reducing readmission rates. Today is Thursday. Yes, today is Thursday, February the 27th, 2025. So thank you, everyone, for joining today. On the call today with me, we've got from the STS side, we've got myself and Ruth Raleigh, our general thoracic consultant. We also have Emily Conrad, Carol Crone, and Nancy Honeycutt. We also have our GTSD workforce chair, Dr. Chris Cedars, joining us today, as well as our guest speaker, Dr. Lisa Brown. And I'll do a formal introduction, Dr. Brown, here in just a few moments. But again, before we kick off today, again, thank you everyone for joining. I know it's been several months since we've all gotten together again. But thank you for joining today. And just a reminder for those, we also may have some new people on the call that this is your first time joining our thoracic quality improvement series. But just a quick refresher before we kick off our presentation today by Dr. Brown, just to quickly review our goals for this quality improvement project. And of course, one of our main goals of this quality improvement project is to, most importantly, demonstrate the value of the STS General Thoracic Database just beyond just beyond our reports and those coveted star ratings. And then also, most importantly, we want to demonstrate how important that you are as a data abstractor are. And then also we want to emphasize, making your STS data actionable for improving the outcomes at your hospital. And then most importantly, we are working with this quality improvement. Our goal is also to help decrease cost. And then also it's a very, rewarding work to work towards something, to work towards an overall goal together. So thank you all for participating. And also for our readmission rates, why do we care? So our readmitted patients, do tend to have those higher complication rates. We have that higher rate of infection. We see that increased rate of mortality. The readmitted patients tend to have the longer recovery times and increased opioid utilization, and also the quality of life impact these readmissions have on our patients. For our healthcare systems, we have those throughput challenges with complications and readmissions with that increased length of stay. We have an increased cost associated with these complications as well. We also do have the decreased reimbursement risk for these readmission rates. And then what was our plan to how are we going to how are we going to initiate this quality improvement? We're going to nationally decrease readmission rates for our lung cancer patients. And we are measuring the baseline data we pulled from our spring 24 harvest analysis reports. And back in October, Ruth did present this baseline data on with the mean readmission rate and the mean length of stays. We use the harvest reports. The sites can use these harvest reports to implement these processes at your sites to decrease the readmission rate. And as we are doing today, STS will continue to provide education and support for these processes. Thanks to Dr. Brown, we have asked her to present today and engaging our site leaders who've already accomplished decreased readmission rates and provide education on these webinars. And then we will continue to track monthly to see improvement nationally over time. And then with that being said, I'm going to turn things over to Dr. Brown for today's presentation. So Dr. Brown, thank you so much again for joining, agreeing to present today. And we are grateful to have you here with us. So Dr. Brown, I'm going to turn things over to you to present on your paper for readmission after lobectomy for lung cancer.
Okay, great. Thank you so much. Thanks for the invite to present today. This is a really great topic. It's something I'm sure you're all well aware that we're interested in. Your hospital administrators are definitely interested. And we want to provide, obviously, if somebody needs to be readmitted, that for optimal care, that is what we do. But, are there ways to prevent perhaps readmissions or other things we can do, or how can we predict it? And so back in several years ago, I looked at the data collection form and I thought, what are some outcomes that that we haven't analyzed yet within our own general thoracic surgery database. And, we focus a lot on 30-day morbidity and mortality, but I noticed that nobody had tapped into the 30-day readmission rate. And so that's when I sent an application into the STS Access and Publications process, and proposing that we look at this and analyze readmission after lobectomy. And we chose lobectomy because we assumed perhaps that after wedge resection or smaller resection that patients wouldn't get readmitted as often. And as you know, pneumonectomies perhaps may get readmitted more or have more complications. And so we wanted more of a cohesive, uniform cohort. And then, I wanted to point out that we actually presented this or submitted it to the Annals of Surgery, which is a journal that applies to all surgical specialties. And I think it was a good way for us to showcase to other surgical specialties that also publish in this journal and the editors of this journal that the STS database is very robust and has high quality data. And so we were fortunate to get this published in that journal. Next slide. So our objective was to identify independent predictors of hospital readmission within 30 days of discharge for these patients who are undergoing lobectomy for lung cancer. And what independent predictors are, and I'm going to talk about this in a bit, there's going to be a lot of data and tables and things on the next pages, but I want to provide you with some just overall rules of thumb on how to look at these numbers and how to interpret them, so that you can better understand your own data and some of the papers that come out of this STS database. We wanted to determine whether, is it pre-op variables or intraoperative variables or the post-op ones, which are most predictive of readmission. And then based on prior studies from other centers and using other databases, we hypothesized that it's probably going to be the postoperative complications, as you understand that would have the greatest risk of readmission. So we looked at readmission within 30 days of hospital discharge to any hospital. So that's really important as well, because as you'll see later at the end about a lot of readmissions are actually to hospitals that are closer to the patient's home, not necessarily to your center. Next slide. So any of these papers where we are trying to assemble a cohort, we have to decide, who should we include and which patients should be excluded. So we looked at patients undergoing an elective lobectomy. Unlikely that we do urgent lobectomies, but elective is also going to make it more cohesive. And then clearly patients who don't have an opportunity to experience the outcome, which is 30-day readmission, such as those who died during their index hospitalization or had a death prior to readmission. Those are patients that obviously excluded. If they were had missing data for death or readmission, though they were also excluded. And then some of the patients who were sicker, like ASA class 4, 5, or 6, that doesn't really in step with elective lobectomy for lung cancer. And then Zubrat scores that were bedridden or morbid, we excluded those patients, but we still had a lot of patients. So almost 40,000 patients in this group. And this was 2012 to 2017, because we also wanted to use data collection forms 2.2 and 2.3 because they had similar definitions for these variables, making it easier to compare. Next slide. So these were our results. The overall 30-day readmission rate was 8.2%. So, about 1 in every 12 patients is readmitted, which is not a insignificant number, right? From a patient perspective, from a family perspective, from the healthcare system perspective. And so what we did, and this isn't the full model, but we made 3 models. And I'm sure you've heard and looked at multivariable models, but what that means is we put all the factors that we think are important into a single model. And you can compare, for example, patients who were admitted and those who were not readmitted, or with those who weren't and weren't readmitted, based on all of these factors kind of one by one. But when you put all the factors in a model and you compare them against each other, it really helps you see which ones are the most important, and which ones kind of fall to the bottom and actually aren't really statistically significant. And so we took all the preoperative risk factors, things that we know about before the patient even goes to the operating room, and put them in a model. And these were the most important risk factors. Those the interstitial fibrosis, steroid use, people who'd had a cerebrovascular accident, and then the Zubrod score 2 or 3. And what this means is that, for example, for steroid use, those who were readmitted, those who use steroids or were on steroids chronically were 42% more likely to be readmitted. And then for those who'd had a cerebrovascular accident, they were 36% more likely to be readmitted at 30 days. And when the p-value for most of these studies is less than 0.05, that means that there's a statistically significant difference regarding this factor between those who are readmitted and those who were not. So those who were readmitted were more likely to have interstitial fibrosis, use steroids long-term, have had a CVA and so forth. When we look at a model like this and we want to say, okay, so how good is this model at discriminating between those who are readmitted and those who are not? And what the statistic that we get is called a C statistic. And that number for this model was 0.600. So this model is okay. If a C statistic is 0.5, that means that model is no better than flipping a coin at predicting which person's gonna get readmitted and which person isn't. Okay, so this model was okay. There were other factors that were key and important, but I just gave you the top ones. Lastly, when you look at something like this and you look at these 95% confidence intervals, what that means is the odds ratio, which is in the second column there, falls somewhere in between the 95% confidence interval. So if you kind of ran these numbers or did this experiment, so to speak, 100 times, 95% of the time, the odds ratio is going to be within that interval. So if it's narrow, that means that we've got a really good estimate here, that odds ratio is probably accurate, and the narrow confidence interval tells us we're pretty confident about our estimates here. And the reason why that is because this is a huge database, thanks to all the participants and all your hard work, such that we have so many numbers. Remember, this cohort has almost 40,000 patients in it, which is huge. This is an undertaking that no participating site can do in and of itself. So let's look at the next slide. The next thing we did was we thought, okay, well, let's see how the preoperative risk factors match up. How do they fare against the intraoperative risk factors? So what do we do in the OR? What we do in the OR, how much does that matter with regards to who's going to get readmitted and who's not? And so what we see is that as we add factors into a model to the ones that are already there, some of them become insignificant, and others, the odds ratio changes a bit. So the 4 that I mentioned in the last slide, the preoperative factors, those were still statistically significant. They still mattered. But the odds ratio changed just slightly. And then we see within the OR, people who received packed red blood cells were more likely to be readmitted, about 31%. And then interestingly, when you see an odds ratio that is less than 1, that means it's protective. So this is, also a good way of kind of checking the data. I would expect that a middle lobectomy would be less likely to be readmitted, right? That's the smallest lobe, only 2 segments. So those who had a middle lobectomy were 25% less likely to be readmitted. But a lower lobectomy was higher. Not surprising, because most of the blood flow dependently goes to the lower lobes, and the lower lobes do a lot more work than the upper lobes and the middle lobe, especially in our patients with emphysema, if their emphysema tends to be in the upper lobe. So the middle lobe and the lower lobe, they're being compared to people who underwent an upper lobectomy. So middle lobectomy, less likely to be readmitted, lower lobectomy, more likely than an upper to be readmitted. And so the C statistic, again, is it's pretty low. It's not It's not great, but it's still predictive and has some value to it. So again, think about these odds ratios and look at how none of them are greater than 2. So then we decided to put in some of the complications. And so let's look at the next slide and see what the complications were. You're all super familiar with all these complications and coding them. And I know there's a lot of numbers in here, but what you can see, again, p-values are very small because this is a huge cohort of patients. And so even small differences between two groups are going to end up having a low p-value and looking statistically very important. And then if that's the case, you have to look at the actual difference between these two groups and say, is it clinically much different or not? And I'd say for a lot of these, it actually is. And so not surprising that for those who are readmitted, kind of hands down across the board here for all of these post-op complications, there were a greater proportion of people in the readmitted group who experienced these complications. So really, it gets at preventing complications is the way to prevent readmissions, right? At least from this data. And now if we look at the next slide, this is where, we found that it's actually in, when you do these types of models, it can be hard to get very large odds ratios. Because most of them are smaller, like I showed you in the first two models, but now we put the post-operative risk factors in and they just overshadowed basically most of the risk factors from the preoperative time frame and then the intraoperative time frame. And we can see here that pulmonary embolus, patients who had a PE, were 12 times more likely to be readmitted. Empyema, about 12 times more likely. Pleural effusion, pneumothorax, okay, people who had a stroke, MI, and pneumonia. And so those were all really driving forces, which makes sense, right? Those are people that they need to be readmitted. So they need a procedure or they need some complex medical care. And these are patients who need to be, rescued from this complication. And the only way to do that is by coming back to the hospital and getting the procedures that they need. And then interestingly, here you see one of those odds ratios less than 1 again is 0.6. So those who had atelectasis requiring a bronchoscopy, maybe they had a mucus plug after surgery and then that was noted on imaging and they had a bronchoscopy and that was actually protective. So those patients were actually less likely, 37% less likely to be readmitted if they underwent a bronchoscopy to help with atelectasis before discharge. So that was interesting. Now the C statistic here is 0.74 if you round up. So this is much better. This model is a lot better than the prior two. And most would consider this a pretty robust model. Now, are these results surprising? They're not. They're not surprising, but I think the key to the way that we analyze these data is that now we can see what the most important factors are, right? And then if you really want to target readmission, you got to target, what are your practices for preventing PE, for preventing empyema or deep surgical site infections, pleural effusions. Something I could think about there would be when you see the patient in clinic after surgery, do they have an effusion at that time and can they get it drained as an outpatient if they have shortness of breath? Pneumothorax, sometimes that can also be managed as on an observation, like 23-hour observation status or outpatient basis. Obviously, central neurologic event and MI, not so much. Those patients are going to have to come in. So next slide. So, we noticed that 1 in every 12 patients undergoing lobectomy for lung cancer was readmitted within this cohort. And interestingly, up to 1/3 of admissions were to hospitals other than where the index operation was done. So that's why we appreciate your effort in following up with these patients at the 30-day mark to see were they readmitted to a different hospital or not. Because if they were, we'd want to capture that for our database so that we have that accurate piece of information. And then not surprising, post-op complications have the greatest effect on the risk of readmission, especially those that require the patient to have a procedure or some sort of inpatient medical treatment. Next slide. That's pretty much what we have. And I think I'd be open to questions about this or about your own sites with regards to how you look at your own data, and do you have a quality improvement structure and infrastructure in place where you can look at your readmission or look at any of your outcomes essentially, and how do you look at that data and how do you make decisions on where to intervene, and then how do you track your progress?
Okay, fine. Thank you, Dr. Brown. We do have the Q&A open, so if you do have questions, please feel free to put your questions into the Q&A. And also, we would love for you to just raise your hand. We have the, so you can just have a conversation and just ask your question. We love to just have a conversation. So feel free to raise your hand and I can just unmute you just to make sure that your microphone is enabled on your end. But thank you again, Dr. Brown, for coming to share your presentation with us. I think Ruth, did you have a question or two for Dr. Brown?
I do. So I think one of the things that you mentioned in your presentation that we have had a fair bit of conversation about is tracking whether or not a patient has been readmitted. I guess I would be curious to know what your personal practice is on capturing that information. I think that some surgeons are seeing patients at 2 weeks, and then data managers are having a really hard time figuring out if a patient has been readmitted or not without contacting the patient themselves. And then the patients aren't really too keen on responding, which I can understand in this day and age. Everything feels like it might be a scam, to be quite honest.
Yeah.
And, I think it's interesting that you noted that only 50% of readmissions actually occur at the original, at your site, right? So you're really having to look for a broader, you need more information than just your EMR, I guess. So I'm curious to know what your practice is. How do you manage that?
Yes, so this is hard, right? Because I think it's easier when you have the episode of care is the operation, and you have the preoperative H&P, and you have all the information that you need. But now we're talking about what happened at 30 days and how do we get that information? So it's a bit of a challenge. I'd say we're fortunate for several reasons. So despite the fact that about, I want to say 85% of our patients drive over an hour to see us. I'm in Sacramento, California, at UC Davis. We have patients from as far as, 3 hours Northern California, sometimes the Southern Oregon border, and so forth. And so if these patients have a problem, it makes sense for them to go to their local emergency department. And so our data manager, Valerie Cooter, is also our outpatient nurse navigator. So she wears two big hats. And I guess when she gets a call from, when the patient gets a call from her, and if it's, labeled as UC Davis, they're sometimes more likely to answer it. And when she follows up, it's a little bit of a check-in as well. So it's a clinical check-in. How are you doing? Have you been readmitted to any hospitals, in the last month? And how are things going? So we get that information, and it kind of serves two purposes, right? A, as a check-in, clinical, but B, provides the answer for the STS database. And I know it's hard because patients, nobody wants to answer their phone these days, right? We all screen because a lot of it's scam likely, but that's the hardest part about it. But that's the importance of kind of getting that piece of data. So I'd be interested in knowing how many data managers are reaching out to those patients at 30 days and checking in, because there's a lot that goes on outside of your hospital, right? That patient may go back to their primary care doctor. They may go back to some other specialist locally. But the one thing that I also question though is I would say that when our patients pop up in an ER that's not ours within 30 days or even within 90 days of surgery, 9 times out of 10, I do get the impression that we get a call from that ER requesting transfer back to us. So in that regard, we would know about more than what we reported here.
Yeah, because you're getting the transfer request, that makes sense. I think, for my site, like locally, our hospital has an arrangement with the local VA health system because I think they didn't have enough capacity, I guess, to do lumbar sections there. So patients may come to our site for surgery, but then all of their follow-up is in the VA. And of course, the VA health system chose to not use Epic. And so like, there's not really a lot of note sharing back and forth. So things can just get pretty tricky if patients are unwilling to, answer phones, etc.
The other thing we have that's new is, and this is all where you're gonna have to leverage your local resources, and this is, I think, been within the last year or two. We have through Epic, and most of you may have this as well, it's called Care Everywhere. And so we're linked with a lot of hospitals around the area, around the region, not all, but some. So I can see admissions, we can see admissions to other hospitals within 30 days. And so we can get information that way as well.
Yeah.
Oh, go ahead. I'm sorry. Valerie had her hand up, but I didn't know if she wanted to. Yeah, Valerie, I didn't know if you wanted to.
Hey.
You should be able to unmute on your end, Valerie, I think.
Hi. So I just wanted to say, as Dr. Brown's database manager, I wanted to tell you that all those resources we have, Care Everywhere, follow-up visits, phone calls, all of those I take for the 30-day readmission. And if there is no documentation in the chart of us seeing the patient at 30 days, I pick up the phone and call them and ask them.
Thanks, Valerie. Yeah, we track them pretty closely. But you know, they have to be readmitted to the hospital, not just ER.
Right,
and-
not just an ER
yeah,
visit. It
Yeah,
has to be
or
an
23
actual
hour.
admission.
Yeah, or 23-hour observation. We see all of our patients at about 10 days after surgery.
Do you see them only once at 10 days and then not again?
We see them once at 10 days, and then if they have a problem, if they are having some problems or issues or anything like maybe pain management or anything along those lines, or if we sent them home with the chest tube for a prolonged air leak, then we continue to follow along. And then if they are doing great after surgery, on that post-op visit, all of our cancer patients, unless they're going to have adjuvant therapy, we do the lung cancer surveillance as well.
Gotcha.
So we do see them. Yeah.
We had another attendee has their hand up. In Markowitz. I can unmute you. If you have a question, feel free to unmute on your end.
Hi, I do have a question. Our facility, we are not based with the thoracic surgery office. We are independent on the quality team. So we don't have the coordination of reaching out to the patients on behalf of the office. As a matter of fact, our coordination team not necessarily reaches out. We don't usually have patient contact. With that being said, I've tried to work with the office manager to have their staff reach out to those patients because we do follow up with surgery within 2 weeks. And then after that, if they've not had any other encounters within our health system or within Epic, we cannot verify that. We do have Care Everywhere. And in another discussion, I was told that we could not take the absence of information for that 30-day follow-up within Care Everywhere, that we would still need an outreach. My question is, if the patient does not answer on a first outreach, how many outreaches are required to satisfy the question of we've made attempts? Is it 2, 3? I couldn't find guideline on that.
I don't think there's a guideline. You would just then be forced to say unknown if you don't know the status of the patient at 30 days. So I guess I would have a conversation with your surgeons. I think most surgeons are invested in knowing this data. I don't know, Dr. Brown, correct me if I'm wrong, or Dr. Cedar. So
Yeah, I have
it's your surgeon's data. I would talk to your surgeons and see at what point do they want you to say unknown versus continuing to try and connect?
I was thinking, yeah, this is key because I see someone else the same issue working with quality, not allowed to call patients and can't seem to get the office to buy into it. Is with regards to that, I know that a lot of you are in different positions, right? Maybe Valerie's part of our clinical team, so we're fortunate with that. But then others of you are going to be with your quality team, and I'd say a lot of hospitals participate in Vizient or other databases that collect readmission data as well. And so I don't know if there's an opportunity within, it may not be the exact same definition. So that's one of the critical things when you look at different databases, right? This database inside and out and the training manual. And then if you go to, let's say, a Vizient database, which is a hospital level administrative database that your chief quality officers pay a lot of attention to, because it ranks hospitals and how they're performing based on a lot of different quality metrics. But they have readmission data. That's a big one. So I think there may be other ways within your health system to get those data through other databases or even through your quality department, for the group of surgeons that are doing these operations. Has anyone tried that? I'd be curious to know if you had any success with that.
Any hand raisers on that one?
Yeah.
I can't see the hands raising for some reason, Leanne.
Yeah, you have to pull up the participant or the participant.
Oh.
Yeah, and then you can say it. But Kelly says, to her knowledge, Vizient will only report a readmission if occurred at the index facility.
I'll see. So they're limited. Got it. So then you wouldn't have the outside ones.
Mm. All right.
Does anyone else have their hand raised? Otherwise, I have another
no.
question.
I don't say anything. Go ahead.
So based on your presentation, I think, so I come from the world of cardiac and thoracic, although I've never abstracted ACSD, but just having been involved in like M&Ms, et cetera, for both sides, there's always a lot of conversation in the cardiac world about did this patient have a bad outcome because, I incorrectly selected this patient for surgery. It seems like from a readmission perspective, really the patient's sort of preoperative status is less important in terms of their outcomes. Again, at least as far as readmission and maybe morbidity, since readmission is very much linked to morbidity, that there's really not a huge impact in terms of who you're selecting, but maybe that's a jump and I'm just not understanding the data.
Yeah, no, I think you got it. Is the preoperative and intraoperative factors don't seem to be quite as important as what happened after surgery. And so the way after I looked at all these data and had all these models and was writing the paper, the way I had it in my head is, you're right, 30-day readmission, let's face it, if you have the operation, you're doing well, you're not coming back. There's no need. And those patients too aren't going to answer their phone because they're happy and they're out doing things that they want to do. But that's the key is, how do we prevent these postoperative complications? Because then that leads to the domino effect of readmission, other procedures, additional complications, and potentially mortality, right? And so a 30-day readmission in and of itself, I think of it as a kind of in a different category of outcomes or adverse outcomes, because it's so linked to the postoperative complications. But then it's also linked to this concept that you are probably aware of called, failure to rescue is, we're going to have complications for surgeons. And there's a saying in surgery that if the surgeon who doesn't have complications actually isn't operating, because we all have them. And so when you have the complications, the key is early identification and an early intervention in order to rescue that patient from the potential risk of death from that complication. So that's the key. And I see readmission plays a role there as well. So at the end of the day, I think it's just one piece of the puzzle, but I think the paper that we published highlighted the fact that, well, these are the real, high value, if you will, complications that we should shine a spotlight on. and work the hardest on to prevent, so that we prevent A, the complication in and of itself, because we don't want our patients to have complications, and then B, the downstream effect of the readmission and the strain on the healthcare system. But then if you take a look back from the healthcare administrator standpoint, if you put that hat on and you say, we want to prevent 30-day readmissions because it's expensive, and it also has some implications for CMS reimbursement. And you say, are there ways that we could have prevented this readmission? So if some patients, yes, they're absolutely going to have to come back into the hospital and be treated. But others, how well can you manage, your tubes and your drains and some of these less severe complications on an outpatient basis, see the patient more frequently in clinic, bring them in for a 23-hour OBS, work closely with your interventional pulmonologist or radiologist if you need them to help you with the postoperative care or management of these complications. And so are there ways around these things? Even at our hospital, this is getting even further down the line of trying to avoid emergency room visits through our cancer center. We have a system whereby we're trying to do a outreach of urgent care at home. So sending urgent care nurses basically out to patients' homes who are within our local area to check in on that patient, to treat very kind of minimal symptoms and things, so that that patient doesn't come to the emergency room, because it's just trying to balance healthcare resources so that we can optimize the resources for all the patients, right? Not that everyone needs to come into the ER and be readmitted. So long answer to your question, but it's really about, at the end of the day, preventing the 30-day morbidity and mortality.
Last question, I promise. So thinking about those projects that you just described, which are incredible, who is part of the team that builds these quality improvement projects for your patients? Is it you and your data manager who's also your navigator, or is there structure around that? How does that work at your institution?
Yeah, it's been a work in progress, and it's evolved over time, but we've gotten really lucky. So what we did a few years ago now is we started inviting one of the quality analysts to our a weekly meeting, and then it actually was every other week. And he's a data analyst, and he worked very closely with our chief quality officer. And so he knew all these databases inside and out, and he was, just a data expert. And so I introduced him to the STS database, and he was impressed, and wanted to look at what we collect versus what Vizient collects. And then your hospitals are going to collect, the patient safety indicators, which is through the AHRQ. Those are postoperative surgical adverse events that I'm sure you may be familiar with some of those. And also the NHSN collects the surgical site infection data. So all of these different metrics are flowing through the C-suite at your hospitals, and they're looking at it, and whether you know it or not, and then reaching out to your surgeons and saying, okay, you need to work on this. You have a problem here. And so we started inviting Daniel Black to our meetings, and we included everyone, the surgeons. Obviously, Valerie was there, as our data manager, and so she could compare and contrast like our STS data compared to what the Vizient data were showing us. And we really have to look at all the metrics by which you're being evaluated by your hospital system and our STS data, and figure out where are the signals in which we could improve, right? Where are we not doing so hot? And then the next step is to look at, let's say your readmission rate goes up, or who was readmitted. Then you got to get the medical record numbers of all those patients. You can start digging into those charts and say, what's going on here? Who are the patients that are getting readmitted? Could we have prevented any of these? And just do like a deep dive into those cases. And then based on the information that you find out, is there any way that, any changes you could make to improve upon what you're doing? Recently we had a surgical site infection uptick, and that was about 2 years ago. And so we thought about, okay, we invited the surgical site infection nurse analyst for the whole hospital, who basically does surveillance on all the surgical site infections in the hospital, to our meetings. And she started providing the data for us. And there are people in your hospital that have these dashboards, and they'll provide you with the data. And then you start to ask questions about how did you measure that? What's the definition of a surgical site infection? And then you again take your cases, take a look at them, see what went wrong. And what we noticed was that a lot of our patients in surgery, every single patient that had a surgical site infection at some point had a temperature less than 36 degrees Celsius, which is technically hypothermic. So patients should be at 36 degrees or above around the entire perioperative period. And so we focused on an intervention where we increased the temperature. We made it part of our timeout at the beginning of the operation. We said this patient needs to stay at 36 degrees or above, raised awareness about it. We used more heating devices in the operating room to keep the patient's temperature up. And then over time, we've actually, nipped that problem in the bud. So that's how we've done it at our institution. And I think the real key is just being very open-minded and receptive, because I think sometimes when hospital administrators and others come at you with, red flags of what's going wrong with your services, there's a tendency to be defensive, but that's not the point. We all want the same thing. We all want to have, provide the best patient care, have the best patient outcomes. And so just understanding the data and how they define it, and then also doing your deep dive, because I'll just say one other thing that's interesting. The more you know, the better off you are. And there was another time when we got all of our patient safety indicators, and we had a handful of them, and we looked at the patients, and we had a PSI 9, which is a post-op hemorrhage or hemothorax in this case. And I thought, gosh, I don't recognize that patient, because we usually remember the patients that had a complication. Obviously, their names stand out in your mind when they're brought in front of you. And I looked at this patient's chart, and I said, wait a minute, this is a patient who went to the emergency department and had a chest tube placed by the emergency department. And then I think they had intercostal artery injury and ended up with the hemothorax. And then we got consulted. I took the patient to the OR to evacuate the hemothorax by a VATS. And so then I got dinged with a PSI 9 for that patient, because I was the discharging physician. And so the PSIs for a particular hospitalization are assigned to whoever the physician was at the time of discharge. And so once you take those deep dives too, then you say, wait a minute, this one shouldn't be assigned to me, or that complication actually, that's doesn't fit. And so having these discussions and conversations with your C-suite and your analysts is really, really, really the way to do it. And knowing how to kind of leverage all the people with all the data in your center to get them to share it with you, and then use it to your advantage to see if you can improve your patient care is the way to go.
Thank you. Super helpful. I think there's a comment in the chat. So Dion said this is sort of what they do at their facility as well, except they do a weekly meeting with the entire team. They look at discharges, consults, and upcoming cases. Within that, we drill down on why there was a complication, an extended stay, et cetera, what happened and what they could do to prevent it. For the upcoming cases, they look at medical history and focus on what we need to make sure we do to prevent any complications or extended stays.
Yeah, I think that's great. Planning ahead for a patient that you know is going to be complex, right? Maybe they have a lot of comorbidities. Maybe they live in a rural area. And I would be interested in knowing is there a way, do any of your teams, like you're saying at your center, Dion, can you plan ahead? Because I know at our center, it's not until the patient comes in to the hospital where we can actually get discharge planning to kind of set things in place. So we can't expedite discharge planning before the patient even gets there, even though we probably know that they're going to need it, right? So I think we get slowed down sometimes by home health and just getting things in place for some of our patients who have higher needs.
Good morning, Dr. Brown. I don't know if you can you hear me?
Yes.
Yeah.
Okay, so I don't know about the discharge planning ahead of time. I do know that the NPs, when they look at the cases ahead of time, so normally the NPs do a quick pre-op questionnaire with the patients like 2 days before they go see the anesthesiologist, and then they'll see the anesthesiologist, so they'll do their pre-op checklist with the patient as well. What they do go over is potential complications with the patients as the surgeon do. And sometimes they're like, okay, do you want to do the stitch removal? So they'll start the pre-op teaching there. They look at the rural areas. They look at if the patient is on any type of, they're doing chemo or radiation before or after, if they're going to follow up with their PCP or come back to the thoracic team. So they kind of look at that and kind of plan. In the weekly meetings, it's normally myself, 3 NPs, 3 physicians, maybe 2, but 3 physicians, and the residents. They normally go over the cases as well. So I don't know so much about the discharge planning, but as far as, let's say, they know a patient has a history of BPH, they may say, okay, the patient has this history. We know they're not on Flomex, so we need to go ahead and start them on Flomex prior to make sure we don't have any issues such as urinary retention, or they've had history of AFib in the past. Let's make sure we start them on their anticoags or get cardiac on board before any complications arise. So, or what they've been looking at too is how much IV fluids they're receiving in pre-op and during surgery. So is that the cause of them going into AFib? If so, we need to talk to anesthesiologists about the amount of fluids we're giving them during surgery. So they kind of look at that. And like I said, with the upcoming cases, they kind of look at the past history, how big the tumor is, the location, if there's any prior surgery to the chest wall, the frailty, and they also go over the percentile now. Since the percentile website has been published, they'll go over, so this patient may be an 80th percentile, so we need to make sure we look at this. We're not just going to round once a day. We need to round twice a day. So they put an extra set of eyes and ears on the patient just to make sure all bases are covered.
That's super impressive. So, because it sounds like your place then has a very proactive approach to really optimizing that patient and getting them ready and
Correct.
anticipating what could go wrong after surgery. And so do you measure frailty out of curiosity? Because I know the cardiac database folks are starting to do that. And I think that we don't do a good job of that in surgery overall.
I do not, but the thoracic team themselves, they go over the frailty, but I don't measure it myself. They do it internally within their department. I'm separate from them,
Mhm.
but I'm still very hands-on with their team, although I'm in the quality department.
Yeah, that's impressive. And it's also some places places have a higher degree of, and say, participation from anesthesia, like an anesthesia pre-op clinic where they
Right.
meet the patient first. We don't have that quite yet. But every place is a little different. So I think it's a matter of just trying to figure out how to assemble a team to prepare, for that, to take care of that patient, right? And their special needs, and to prevent just basically what could happen after surgery for this patient, right?
Right, right.
That's great. And is that driven by, that initiative then, is that driven by your surgeons or your hospital administrators and so forth?
It was primarily
cut down.
driven by my thoracic surgeon, by the champion. His name is Dr. Min Kim. So it's
Oh, yeah.
primarily driven by him. And then Dr. Shahara, and then we have a new surgeon called Dr. Naselsky. They're on board with it as well, but he's the driving force behind it. And him and his NP, her name is Leo. So they're the driving force. And he also has his assistant. She goes over the caseloads as well and follow-ups and any CTs that may need to happen on follow-up to make sure that the CTs are happening, labs are happening, so she's very hands-on. So the whole thoracic team is very hands-on, but a lot of it is really driven by Dr. Kim.
That's great. And I think it's great. And I think at the end of the day too, though, you all are looking at the data in a way that not even your surgeons are. And so if you're seeing signals in the data, not just the reports, but kind of as you're, recording, you think, gosh, we're having a lot of this complication or that, and then run a quick query, in your own institutional data and say, okay, do we have an uptick in, urinary tract infections or something like that? And then, don't hesitate to bring that to the attention of your your team, because it may otherwise may go unnoticed perhaps, unless you're really taking a deliberate look at all of those complications, which would be very hard to do, right? So say
Right.
lobectomy or lung cancer resection, and then, you know, how many of us really have a dashboard put together that has all those complications and we know exactly, you know, how we're trending, right? We
Right.
don't. That's an ideal state. But I bet most, if anyone has it, I would love to hear from you.
Yeah.
We
Feel
need
free,
a playbook.
feel free to raise your hand. Speak up. Absolutely.
Oh, yeah.
This is Carol, Leanne, and Dr. Brown. And Ruth, I just want to jump in and say, first, Dr. Brown, thank you so much for presenting and for continuing the conversation beyond your presentation
Mhm.
about different quality initiatives your site's doing, and also for Deanne for joining in and sharing what their site is doing. This is the purpose of these quality improvement calls, is because so many sites are doing things to improve the outcomes of our patients. And this is really the platform to share those ideas and to answer questions from one another. What did work? What didn't work? What struggles are you having in getting patients the best outcomes that they should have? And of course, the whole kind of environment that, or the whole impact of the patient's outcomes has on the hospital system, both locally and nationally. So I just want to say thank you. It's really important to me and to STS that we continue to use the database to drive quality at the local and national level. And we really want to have, if anybody else is interested in presenting on what your hospital is doing, and just, this is really a conversation among peers and among leaders to see how can we do this as a team, and how can we improve these outcomes and care of our patients together. And maybe we can even have a significant impact nationally to where we, both decrease cost and increase quality, and lead to that improved value for the patient and outcomes for the patient. So I just really want to say thank you from the bottom of my heart and from STS to show the ability that we have when we get together and work together for these types of initiatives. Thanks again.
Well said, Carol Crum. Any other questions or comments for Dr. Brown?
Question in the Q&A about whether the Canadian frailty score can be used instead of ECOG. You would just have to have a crosswalk back. And I'm not familiar enough with the Canadian frailty score to tell you whether it can or cannot be crosswalked. So I can look into that a little bit further, unless another data manager who's on this call is currently crosswalking Canadian frailty.
Thank you, Ruth. I didn't even see that.
I think I know a little bit, and maybe Dr. Brown or Dr. Cedar know more about the Canadian frailties. It's called CFS, and it's I believe that the NCDR does use some type of crosswalk in their data collection for cath PCI, where they use that score to determine how the level of the frailty, instead of providing each answer to each of those questions on the Canadian frailty schedule survey. It's one answer to where it's, on a spectrum of patients' frailty. Oh, don't know if that helps, not, or if anybody else has anything to add.
Yeah, I'm not as familiar with that one. There's so many frailty metrics out there, and one thing to keep an eye on in the pipeline is part of the STS evidence-based surgery workforce. We're actually on a writing group and trying to figure out, how to best assess frailty for our thoracic surgery patients, and then, what to do about it, right? So this is an area where there's so much work, but we don't really know how to use it. And the other hard part is time, right? How much time does it take to measure frailty? Because ideally you want there to be a physical component, like how long does it take for the person to stand up from a seated position, grip strength, and those sorts of things. That's ideal. I think it would, my hunch is that it would be hard to swap out ECOG with any of those frailty scores, because ECOG is pretty well entrenched in the in the oncologic world. And it helps us establish a norm between us and our medical oncologists and our radiation oncologists when we're trying to give an idea of a patient's performance status and then deciding what treatments they might be able to tolerate or, endure as part of their cancer treatment.
Perfect. All right. I'm not seeing any additional questions come in, Dr. Brown, or any hands raised, but as Carol said, we are actually right at the end of the hour. So again, I just wanted to thank you so very much, Dr. Brown, for coming today and presenting to us. And again, as Carol mentioned to the group, if you are doing any sort of quality improvement project at your institution, we would love to have you come on our next webinar and present to the group and have these conversations. But with that, Dr. Brown, thank you again so very much for coming to present today. We appreciate it more than you know.
Thank you very much. It was a great opportunity, and I'm really thankful for all the hard work that you all do to contribute to this database. And it's like Carol said, it's a win-win, because then we have more data that we can look at a national level, and we can find rare outcomes or some rare predictors of certain outcomes, right? Because we have powers in the numbers. But then now you have track of your own data, and you can look at this. I think the strength for each and every one of you then is to look at your own data and say, what are we doing? How are we doing, and how can we improve? And that's the key. And I think the other key to quality improvement a lot of us forget about is, we look at our data, we find where the problems are, we do the deep dive, we come up with an intervention, we implement it, we see things get better, and then we pat ourselves on the back. But we have to remember the sustainability component, because you can always backslide as well, because when you're in the throes and enthusiasm of a quality improvement project or initiative, you're probably going to make things better, which is awesome. But then you can't get complacent, because you could always backtrack as you start to look at other components of your care. So that's key. But you have the data to keep track, so that's great.
And also share with your colleagues so we can all do good together.
Oh yeah, definitely.
Keep it going and share your results and your failures. I think it's great, Dr. Brown. Thanks so much.
Thanks.
Yeah.
Thanks, everyone. Thanks, Dr. Brown. We appreciate it.
Thank you.
All right.
Good job, Ruth. Good
Yep.
job, Liam.
Thanks, everyone. We'll see you on our next quality improvement webinar. And then we also have our next monthly webinar. So thank you again, everyone, for joining, and we'll see you on the next one. Appreciate it.